Meet George.
George has a developmental disability. An individual with a developmental disability is defined as having significant limitations to cognitive and adaptive functioning, and can have disorders such as Down syndrome and autism spectrum disorder. Like 40% of people with a developmental disability, George has also been diagnosed with a mental illness. Mental illnesses can include depression, anxiety, eating disorders, and others. When patients have both a developmental disability and a mental illness, they are said to have a dual diagnosis. Often, this means that they will require extra support, sometimes given in the form of tertiary care, which is a form of care designed to give directed and advanced treatment to individuals with complex issues. Here in London, the Parkwood Institute of St. Joseph's Hospital has a 12-bed unit specifically for these patients, where they are specially tended to by a broad mix of healthcare professionals.
So, what's the issue?
Dual diagnosis patients often have a poor quality of life. This is in part because treatment practices for these patients are underdeveloped and have not seen major changes in decades. 40 years ago, healthcare practitioners were using methods of treatment that weren't ideal. Some patients needed to be isolated or even restrained because they were at risk of hurting themselves or others. 4 decades later, here we are. Not much has changed, as many of these outdated practices are still used today. Due to the complexity of their cases, dual diagnosis patients are often improperly medicated or over-medicated and denied services that are normally used to treat similar conditions. The shortcomings in standard level of care are indicative that dual diagnosis patients like George are in need of an updated, more modern approach.
So how will we address this issue?
We'll be analyzing Parkwood Institute's dual diagnosis unit and recommending ways to improve their current standards of care. By researching evidence-based strategies, identifying novel treatment practices, and examining leaders in this model of care, we will uncover the best practices for dual diagnosis patient care. We will consider aspects of the program such as behavioral support strategies, the skills mix of inpatient staff teams, and creating a smoother inpatient to outpatient transition.
What will the impact be?
The information we find will be given back to Parkwood so it can be used to create a better, more modern model of care. Our conclusions will be offered in the form of a literature review and a presentation to enable the dual diagnosis program to enact positive change. By acting as a potential agent of change for the dual diagnosis program, we will improve the quality of Parkwood's care in the London community for the betterment of people like George.